I have a disclaimer, and that is I'm not a physician, I'm not an attorney, and this is risk management advice. So here are your objectives for the program. You'll be able to discuss ethical considerations associated with the use of generative AI, apply 2 frameworks to evaluate healthcare AI, and articulate your role in AI at your organization. So before we get started with the slides, I'd like to sort of clarify that there's a lexicon around AI. And the definition of AI as artificial intelligence came out of a computer meeting at Dartmouth in the 1950s. So it's probably time to start looking at how we're defining that. The American Medical Association is recommending augmented intelligence. I'm sure that as with any disruptive technology, the terms will change as the technology grows. What I'm going to do is use the term AI. And for pre-generative AI, I'm just going to say AI. And then for anything other than that, there'll be a prefix or a suffix. So that said, let's get started. These cases are examples of, well, I call them cautionary tales of using artificial intelligence. So these are older, but they're pre-generative AI, but they're examples of what can happen. So it's good to use these to lay the groundwork. So 2016, Microsoft was working on chatbots, and they were interested in evaluating what teenage girls do online. So they created a chatbot named Tay to interact with teenagers. And they released Tay onto the internet, and there was some publicity associated with that, which attracted internet, I guess you would call them activists, who trolled Tay for hours, asking question after question after question. Some of them were very inappropriate, and what they were trying to do was figure out the guardrails on the program, and unfortunately that sort of behavior had not been anticipated. So Tay learned from her trollers. It was almost like a brute force attack, and she rapidly became a foul-mouthed racist program. And before Microsoft could before they identified the problem and shut her down, she tweeted 95,000 times. I know it's called X now, but I have a hard time. She X'd 95,000 times. So this is an example of what happens when you don't understand the environment that you're using your AI in. And I say that to you because some of these products are developed sort of for general use. And when you apply them in healthcare, there's a whole different set of considerations and regulations. So bear that in mind as we go through the program. In 2017, Facebook AI Research Lab was working on logistics, and they were using dialogue or fulfillment agents. Think about internet commerce. And so they had tweaked their dialogue agents to a point where they were pretty happy with the results, and they thought, well, how can we make this better? How can we get more out of our dialogue agents? So they selected 2 programs that had been performing exceptionally well and thought, well, let's have them work together. Let's give them a big problem to solve and direct them to work together, negotiate, and see what happens. So when the program period was over, the scientists and engineers were thrilled with the results. The Alice and Bob had performed very, very well. And when they pulled back the curtain to look and see how Alice and Bob did it, Alice and Bob had created their own language, and the experts at Facebook were unable to decrypt the language, so they pulled Alice and Bob down. And there's 2 sort of things to think about in terms of this particular case. First, this is kind of the first recognizable example of a black box. Alice and Bob did a great job. The output was wonderful, but nobody could tell how they did it because the programmers didn't tell them to communicate in English. So there was no way to see the math, if you will. And that's an example of a black box. It's also an example of how important it is to make sure that everything is in place before you turn it loose. And so this incident occurred in a laboratory. So that's great. It was in a controlled environment. Think of all the times that healthcare information technology or connected medical devices are sort of released into the native environment without being tested in a controlled environment. 2018, Alibaba. So let's talk about Alibaba for a minute. It is a huge international conglomerate, and they do sales and e-shopping. And of course, they use AI for that. And they're based in China. So Alibaba decided to test the efficacy of their language processing AI. So they set up a study where the AI would take a Stanford reading test and a control group would take the Stanford reading test. And Alibaba's language processing AI outscored human controls in reading and comprehension. So reading is one thing. Comprehension in 2018 is pretty impressive. So the cautionary tale here, once again, is twofold. The first one is we have to realize that these environments, that AI, even though it's in your office or it's in your hospital, there's an entire global AI network out there. And so it's really important to make sure that the AI is very protected from being manipulated. And this is also a reminder that other countries are at or beyond where we are in terms of technology, and we kind of need to be aware of that. And then in 2019, California started reporting self-driving crashes. Self-driving cars had been on the road in California since 2016, but somebody in the California governmental structure said, hey, we really probably ought to be looking at self-driving car crashes. And so they started collecting data. And this is important because California was the first state to do that. And the National Highway Transportation Safety Administration didn't start collecting that data and mandating reporting of self-driving crashes until 2021. So this is a perfect example of innovative technology development exceeding the ability of the federal government to control it. And so in this case, California controlled it. In the case of super AI or generative AI in healthcare, really the institutions that have developed and are working with the algorithms are controlling it. So as long as we're talking about controlling super AI, let's move from the past to the present and maybe a little bit into the future. Superintelligence will be the most impactful technology humanity has ever invented and could help us solve many of the world's most important problems. But the vast power of superintelligence could also be very dangerous and could lead to the disempowerment of humanity or even human extinction. Excuse me. So think about that for a minute. Where is this quote from? Is this from a movie? Is this from a sci-fi novel, maybe one written by Isaac Asimov, Philip Dick, or William Gibson? No, it's from OpenAI, announcing their intent to get some control over superintelligence, in other words, generative AI, by using what they call super alignment. And super alignment is important because we need scientific and technical breakthroughs to steer and control AI systems much smarter than us. So this was last year in July, this blog post came out. And basically it was a job posting. They were talking about super alignment and what they meant by it. So when you think about using a computer, or you think, for example, electronic medical records, alignment means you and the computer work well together. You know what you're getting, and the computer knows what you're asking, and the human is the master. Well, how do we do that with superintelligence when it's much smarter than us? So that's super alignment, and they were advertising for computer experts and engineers to come and work for them. So I think that, oh, and I do want to talk a little bit about human extinction. I'm a risk manager. So when I see that, I think existential risk. We don't address that very often in healthcare risk management, So I decided to Google existential risk and AI, and I found a whole bunch of different resources. Some of them were good resources, and some of them were interesting resources. What I did find, though, was there was complete alignment between Stanford University, and they have a whole sort of breakdown on the existential risks of super AI. And so do the Joint Chiefs of Staff of the US. So, and they both agree that autonomous weapons systems are the most significant existential risk presented by these devices. So fortunately in healthcare, we don't really have to deal with weapons systems very often. Usually people bring them in, and I don't think they would bring in something like that. But these are the kinds of things that we have to think about when we look at this type of technology. So let's bring it back down to the present and start moving a little bit closer to healthcare. I was just trying to give you an idea of sort of the external environment in terms of AI. So when we look at AI, generative AI is the second iteration. It's 2.0. The AI that we had before was smart, but it couldn't act semi-independently. It was an algorithm, and it responded based on its programming and how it was directed. And then the breakthrough really was generative pre-trained transformers. So this is, think about a super search engine. You ask a question, and this thing not only can search and find, but can also sort of anticipate and create. So you will have seen examples of this in your phone, especially if you have an iPhone. When you started typing an email, you might get a suggestion of the next couple of words. If that's happening, that's a generative pre-trained transformer. And when it's associated with a large language model like ChatGPT, Chat is the large language model and GPT is the generative pre-trained transformer. But we're beyond that now. So I want to talk a little bit about ChatGPT and the fact that it's a two-way conversation. There's a person who's prompting ChatGPT, and ChatGPT is responding. It's typically not a group effort. And so recently, a program called ChatGPT-O has been developed. They're promoting, and I'm not sure it's widely available, but so it's like a group chat. So think about any digital meeting that you attend like this one. Imagine if some of the attendees were AIs, generative AIs, right? So my first thought, so I always think about how as a risk manager, how would I see this working? So, you know, I see it in education, and I see it in M&M conferences and things like that. But as a mom, I saw it as my millennial son and his buddies having a generative AI in their Monday night Dungeons and Dragons games. So I will get the inside scoop on that. The next iteration is multimodal models. So chat is a large language model. It's language related. Multimodal models incorporate other modes like video, audio, the ability to create artwork. The possibilities are kind of endless. So if you think about early computers and how limited they were. And as the computing power became greater and the chips became smaller, there were a lot more things we could do until we got our phones and you had a computer in your hand. That's kind of what a multimodal is. It's ChatGPT on steroids. It can do all sorts of different things. And I see that being very effective in healthcare. Think about interpreting X-ray images, right? They need to be able to look at the image. It needs to be able to look at the image. It needs to be able to look at the structured and unstructured data, what's in the record and what was requested of it, and then generate a report. That requires a bunch of different models. So those are the sort of most common ones now. And then two more that I want to talk about, and then we'll actually get right down to where you are. Intuitive AI is Apple also uses intuitive AI, and that sort of plans ahead and thinks about what you need. So if you have an iPhone and you're using the calendar app, you will get pop-ups now that say your meeting starts in 45 minutes, and if you leave now, you can make it on time. I don't know how helpful that is, but I can see this in terms of like a friendly house where it knows what time you wake up and it changes the temperature and turns on the light and starts the coffee. You know, that's kind of how I see intuitive. Perhaps there's a place for that in healthcare, you know, thinking the operating room and preference lists and equipment and things like that. I don't know, greater minds than me, but that's intuitive AI. And then biological AI, ooh, biological AI is kind of what you think it is. So let's look at it. So there's an actual real world example of biological AI out there. It's from the World Health Organization. The developers it's called Sarah. The developers call Sarah a digital person, and she is built using biological AI. So it's there, you know, it's proprietary technology, but when you look at biological AI, what typically is talked about is a program that learns not necessarily from databases, but from interacting with humans. So kind of like Tay, except Tay wasn't a supercomputer, it was just a chat program. So Sarah is a digital health promoter prototype, so a public health chatbot with enhanced empathetic response. That's where the biological AI comes in, powered by generative artificial intelligence. So two things here. One is Sarah is experimental. So you can interact with Sarah, and it's kind of fun. I did it. You have to click on the link. There are two permissions required. One is for access to your audio and video on your phone, because Sarah needs to see you to communicate. And the other is Sarah's a prototype. So it's a research project and you're participating in research. I thought it might be interesting for you to see what Sarah looks like. I can't link directly to her because of the permissions, but I do have a still of her face. So if you click on the QR code, you can see what Sarah looks like. And this is really important. And this is one of the reasons why this type of biological AI is a new discipline. When you think about human avatars, there are really cartoony ones, there are really, really human looking ones, and then there's this thing in the middle, and that's called the uncanny valley. So think about the commercials of babies with adult heads talking. Personally, I find that very creepy, but that's the uncanny valley. So they're trying desperately to avoid the uncanny valley. And when I looked at it, I thought, you know, the picture isn't bad. She's designed to represent, you know, be relatable to a whole bunch of different audiences. But when you communicate with her, I found it not something that I would probably take advantage of. But anyway, have a look. That's Sarah. So the next one is called DishBrain. And DishBrain is biological neurons that interface with the computer. So it fuses living mouse and human cortical neurons into computing devices to create machines with biological intelligence. Why would you want to do this? Well, first of all, human neurons can process and take in and put out way more information or bits of information than a chip, even a supercomputer chip, and much more quickly, much more effectively, with much less power requirements. On the other hand, we are talking about human tissue. And so, so far, DishBrain has played Pong, which is, I would say, maybe late 1980s Atari video game. So that the scientists are very happy with that achievement. When I saw that, I thought, well, Pong, that's, you know, kind of a crude game. But on the other hand, they were very proud of it. So I read the article, and this is one of the things I learned. Although the use of induced pluripotent stem cells for biological neuronal experiments is currently not a cause for ethical concern, so let's stop there, because there's two things. First of all, they're using stem cells that's where the cortical neurons come from, the human cortical neurons. Because when I read it, I thought, where are they getting the neurons? Because that's how my brain works. And of course, it went to sci-fi and horror places, but they're using stem cells, and they believe it's not a cause for any ethical concern. I think there are a lot of people who would disagree with that. And so I don't think you're going to be using dish brain in your organizations anytime soon, but I'm sure we'll be hearing a lot more about whether or not it's ethical and how it's legislated and that sort of thing. But the authors went on to say, it is important to consider at what point the collections of neurons should be considered sentient. Oh my gosh. There are so many corollaries in our modern society right now to that. So what I would say is, you probably aren't going to be seeing this in your organization soon, but it's out there. And it does kind of make me think a little bit about Elon Musk's Neuralink. So the question I ask myself, so Neuralink is a chip that is placed in the person's brain, and there are tiny little wires that attach to sections of the brain. And recently there were problems with some of the wires becoming disconnected. There's only one person that has the Neuralink implanted, although the Food and Drug Administration has just stated that they are going to permit another person to do it. The individual is quadriplegic and has been able to play chess, computer chess, using his brain. So it's kind of interesting. I'm not sure it's artificial intelligence, though. I think this is a true example of augmenting. The human body isn't functioning well, and so they've added this element to augment. It kind of makes me think of the $6 Million Man. But anyway, so that's dish brain and biological artificial intelligence, and already we're seeing spokes that don't necessarily have a category for them. So let's bring it down to where you are. Let's bring it down to the pragmatic, where the physician meets the patient. And I want to start with a case study. And this is, it's a compilation of real world calls that I received on the helpline. We answer calls from insured members on every topic you can imagine. And I happened to get a bunch of AI ones last year. So what you see here is a AI coronary computed tomography angiography image in the upper left, and then 3 images from the CT portion of the study. So this story is an amalgamation of it isn't a specific group or individual. It's an amalgamation of the calls. So just say that there's a freestanding full-service cardiology practice, and the cardiologists have purchased an AI CCTA unit, and they have a few questions. And so the first question is, the vendor who sold them the unit told them that the images were diagnostic. So the cardiologists are wondering if they need to review and sign off on the AI readings. The business manager of the practice has other questions about the implementation of this tool. So let's look at 4 questions. I'm going to go through each question one by one. I'll give you a minute to think about it, and then I'll talk to you about what we came up with in terms of a response to the actual questions. So what are the risks associated with cardiologists reading and authenticating AI-produced results? So the cardiologist reading and signing off on the produced test results. So the short version of this is, it doesn't matter whether it's AI or not. You still have responsibilities for the tests that you order. If you're the ordering provider and you're capable of interpreting, so angiography, cardiology goes together. It's the normal risks that are associated with practicing medicine, and that's why you have insurance. So let's change the question up a little bit. What are the risks associated with the cardiologist refusing to read and authenticate the results, i.e. deferring to the AI? Well, now that's a whole different question. one could argue that it's the standard of care for the cardiologist to review the study and authenticate. When it's augmented intelligence, artificial intelligence, super AI, we don't really have a standard of care yet. So then you have to sort of fall back on other areas of practice. So the one that I thought of first was EKGs. EKGs have been reading themselves for probably at least 15 years. And I remember when that first came out, and I was in a hospital setting as a risk manager and had to have conversations with the cardiologist and internal medicine specialist, that a human definitely had to read and authenticate the report, at the very least for billing purposes. So there are lots of risks associated with the cardiologist refusing to read, to the cardiologist, to the organization. And so if that is an issue in a practice, then that should be brought up to the governance level, whether it's a CEO or a board, to determine. And, I guess the argument that I would make as a risk manager is, do you want to be the precedent? The third question, who is responsible for reading the CT portion of the scan? So I'll give you a minute to think about that. So I don't think it's the cardiologist's responsibility unless they have specific training and demonstrated competence in reading chest CTs. Otherwise, if they do not have that, then we can't just ignore the CT portion of the scan. Let's go back and look. There's a whole lot of real estate in here that could have problems in the CT portion. So you got to have someone look at it. And typically that would be a radiologist that specializes in chest and abdomen, or chest and abdomen CT, but somebody needs to read it. And so before I get to the fourth question, how does that happen? So in a multidisciplinary practice that has its own radiology services, there would be a radiologist who could read the chest portion. In a specialty cardiology practice, they're going to have to figure that out. Are they going to hire somebody? Are they going to use telehealth? Are they going to use a contractor? But you can't ignore the non-cardiac portion of the study. And so that gets us to the next question. How should the radiologist document their portion of the study? Very interesting, right? This is not quite uncharted waters, but pretty close. So what we decided was the radiologist would do the typical reading that the radiologist would do, and then they would document reading CT interpretation limited to non-cardiac portions of the study, right? You have to clarify what was read. And then there's all sorts of issues around billing and who takes care of any findings in the chest part, because it's not going to be the radiologist and it might not be the cardiologist, but somebody has to refer that to an appropriate person to address. So lots and lots of complications. So let's get to your role in AI. And so what we're talking about here in terms of, you don't have to be an AI expert, right? You just need to know that AI is being used and how to use it responsibly. Is it being responsibly used? And so when you look at bringing in new technology to a healthcare organization, it's a complex system. There's external forces like regulatory and billing and that sort of thing. There's internal administrative processes, policies and procedures, training, etc. Then there's the workflows. Then there's the end user. You're an end user of AI if you're using it in healthcare. The patient is an end user of AI if you're using it in healthcare. So the end user interface is where the physician and the patient and the AI come together, where the interactions occur, and that's where you're responsible for appropriate use. So in this program, I identified three key considerations for you. The first one is, does everyone know that AI is being used? And that's an example of transparency. The second one is there a process for AI QA? And I'm going to show you two different processes. And the third one is, do end users know how to recognize improper AI function and output? And that's actually the patient safety part of your role. Is it working? Is it working effectively? Can you trust the information that you're getting? So when we look at transparency, that's kind of that you know that AI is being used. So the first statement, you should know that an automated system is being used and understand how and why it contributes to outcomes that impact you, comes from the White House Office of Science and Technology's Blueprint for an AI Bill of Rights. And it's a great document. I don't think it's necessarily your responsibility. I would share it with a practice manager if you're using AI, and if you're in a hospital, I would make sure that at the very least, the ethics committee has taken a look at it. The second one, implementation of AI-enabled tools and systems continues to increase. It is essential that the use of AI in healthcare be transparent to both physicians and patients. Hooray, that's the American Medical Association. And so it's important to be aware of their principles for augmented intelligence, because they're the organization that represents you and you know, advocates for you on Capitol Hill and creates tools for you to use. And you know, this presentation is an example of how that trickles down to the Florida Medical Association. So now let's talk about associated with the use of AI. So this is automation bias. And automation bias is the tendency to accept suggestions from automated decision-making systems and ignore contradictory information made without automation, even if it is correct. So I think some of you may have heard of the big hubbub in nursing about not being included in AI implementations in hospitals, and at the bedside, AI is making decisions that the nurses don't agree with, and there's no way for them to correct the AI or get that information up to where it needs to go. I think this is really a situation where automation bias might be in play, that you know, reliance on the technology as opposed to the humans that are actually on the pointy end of the healthcare. But I'll give you a really great example from the literature. So this was a study that was published in JAMA in 2023, and it was vignette-based study. And what they did was give clinicians 6 vignettes, and 3 of the vignettes were AI interpretations that were normal, not biased. And 3 of the studies were biased AI interpretations. And then, so they were randomly assigned to groups. And then they were either given instruction about the risks of, for example, automation bias and over-reliance on the equipment, and some of them weren't. And what happened was the standard models improved diagnosis across the board. Systematically biased AI vignettes decreased diagnostic accuracy even when the provider had been randomized into the warning about AI discussion. So what do you do about that? You know, bias is a really hard thing to deal with. Think about implicit bias that we've been talking about. Well, the implicit association test was developed in the 80s. So what I found were articles that are looking at solving that problem on the AI side of the equation. So 2 articles, 2 strategies. So the suppression of misleading AI recommendations. First of all, AI should be recommending, it shouldn't be directing. And the recommendations need to be appropriate. So if you think about margin of error, you want to make sure that the interpretation that you get is in the zone where there's least likely to be an overread or an underread, a false positive or a false negative, right? So you want a narrow window. So even though they say suppression of misleading recommendations, what they're really talking about is using advanced statistical techniques to narrow down the reliability of the responses. And so if you can truly be assured that the responses are accurate, then there wouldn't need to be automation bias, because you would know that it was accurate. And then the second one was avoiding the use of prescriptive language. So instead of saying you must, or the first thing I thought of is when you're doing online shopping and there's, you know, the little star or the little flag that says our pick, you know, that's prescriptive language. AI shouldn't be doing that in healthcare and especially clinical decision support. And then on the patient side, we worry about manipulation. And so that's chatbots persuading people to take actions against their interests. And there's more than one case, but in particular, the one that first popped up in the literature was a Belgian with severe depression, where his family talked to him about seeing a doctor, his doctor talked to him about seeing a therapist. He chose a chatbot and committed suicide after 6 weeks. It's hard to tell. There isn't enough information. There isn't a big enough sample to determine whether or not the mental health chatbot was manipulating the patient. But this is a significant consideration, because a lot of the use of AI in healthcare is chatbots who answer postoperative questions, who provide discharge instructions, that sort of thing. So we have to make sure that they're performing appropriately. And the strategies to do that are the World Health Organization has 2 guidance documents. One is the 2021 6 Principles of Ethical AI Use. And then in January of 2023, they released guidance on large multimodal models. You don't need to read the whole one, but that one actually has a table in there that the first column in the table is use. So is it clinical decision support? Is it patient education? Is it clinician education? The second one is the benefits. The second column is the benefits. And the third column is the risks. So if you want a really nice, short and sweet discussion of the risks of AI, that's where it is. The Federal Trade Commission feels that manipulation is a deceptive or unfair practice, and they are aggressively looking for examples and litigating them. And there's been quite a bit of work around informed consent. And then the federal government, our first regulation related to artificial intelligence algorithms is in HTI1, which is Cures Part 2. And it's the acronym FAVES. You know how the federal government loves acronyms. So let's take a look at that. FAVES is fair, appropriate, valid, effective, and safe. So fair, do the models exhibit prejudice or favoritism? Are they biased? Appropriate, are the outputs matched to produce the results appropriate for specific contexts? So you wouldn't use an adult AI on a kiddo, and you wouldn't use pediatric AI on adults. So appropriate use. Valid, are the outputs, do they make sense? Do they align with internal data and external data? I mean, that's one of the ways you're going to know that it's working correctly. There's going to need to be validation, testing, and studies. Are they effective? Does it have demonstrated benefit in real-world conditions? So think about drugs that are pulled out of phase 2 and phase 3 clinical studies because they discover they're not effective. So the AI needs to be effective under real-world circumstances. And so as more testing is done, more AIs are going to come into the healthcare arena. So you kind of need to be aware of these sorts of things. And then safe. Do the benefits outweigh the risks? You make safety decisions every day in your practice. You just need to sort of think about it from an AI perspective. So that was the FAVES framework. And now let's look really quickly at the National Institutes of Safety and Technology Risk Management Framework. And this is what it looks like on the left. And this really is an IT function, probably to own, but everyone should be involved. Governing AI requires a multidisciplinary team and an enterprise risk management approach, and physicians should be on that team. You can help them identify, stratify, and prioritize risk. You can help guide what kind of continuous monitoring is needed. If you're doing pathology, AI pathology reads, where is the latest information coming from? You know, the new decisions, how is that getting into the system? How are the results from the AI comparing to, you know, the CAP studies about different types of cancer and how they should be diagnosed? You need to have a report card, a balanced scorecard, a scorecard for the AI. Continuous monitoring is important, and it's really kind of the responsibility of the AI team, but you need something to show you that the AI is working. So think about peer review and scorecards that physicians may have at recredentialing time. Well, we need to have something along those lines for providers to know that the AI is working within expected guidelines, and everybody needs to be trained. The risk associated with this is that AI and humans don't necessarily work well together. And so the AI part of the human AI interaction can amplify human biases, leading to more biased decisions than the AI or the human alone. So it's kind of like, you know, you're a product of your environment. Your relationship with the AI can be affected by being in the environment of the AI. So how do we fix that? Or how do we address it? Well, we make sure that technical standards and certifications like the NIST risk management framework are used to define the AI. We implement a process for making sure that the people who operate the AI device and the practitioners are proficient with use of the equipment and are able to determine if the performance seems to be off and the results are trustworthy or not. And so that gets us to consent. And when we think about consent, we have to think about, do we need to have consent? And the transparency recommendations from the organizations that I mentioned to you and others suggest that at the very least, patients need to know. So informed consent for AI, there is a huge, this is a battle. This is an unsolved problem yet. And the biggest question is it possible for a patient to be informed about AI when, you know, how can they understand all the complexities of superintelligence when most of us don't? And how can the provider assist the patient with that when they may not have that level of knowledge? And so those are bigger discussions than for us, but some organizations are starting to use AI consent. Then we have standard of care. It's not a standard of care yet to use AI. Who knows if it will become one or not, but we have to keep an eye out for that, because how's a small practice going to compete with a multidisciplinary practice that has AI? How's a critical access hospital going to survive if they can't afford AI and it's an expectation? And then if you're considering informed consent, can patients refuse? Right now they should be able to. We'll have to see what happens later on. And then this is the last slide. What do you need to know? What is your role? You need to know if your organization is using AI. You need to know the training that is available to you. You need to know what standards and guidelines the organization has adopted. How would the concerns be reported? And to whom? I think that's the issue with nursing. And then, are there any specific recommendations or requirements around documentation? How are you going to document if you disagree with the AI? So those are the things you need to think about. And I have a list of references here. And here's my contact info.